Good morning. I'm going to do better. Good morning. A question. How many of you have a friend or family member with Parkinson's disease? Just raise your hands up. Raise your hands. So just take a look around the room. So I'm a neurologist. I care for individuals with Parkinson's disease. Maybe we'll go to the next slide. This disclosures. So we're in the midst of a Parkinson's pandemic. Right now, neurological disorders are the leading source of disability in the world, and the fastest growing neurological disorder is not Alzheimer's disease, it's not stroke, it's Parkinson's disease. From 1990 to 2015, the number of people with Parkinson's disease around the world has more than doubled to over 6 million, and based on conservative demographic estimates, the number of people will more than double again in the coming 25 years. Everyone's lifetime risk of dying in a car accident is 1 in 100. So we all wear seatbelts. We get safe cars for our kids if we can afford them. We thank MAD for their efforts to reduce drunk driving. Our lifetime risk of developing Parkinson's disease is 1 in 15. And I would largely say we do nothing. 40% of Medicare beneficiaries with Parkinson's disease do not see a neurologist for their condition. Those that don't are 20% more likely to fracture their hip, 20% more likely to be placed in a skilled nursing facility, and 20% more likely to die. Every day, people in the United States with Parkinson's disease die prematurely, even though we spend 40% more per capita on healthcare than any other country in the world. If you think about the way we provide care to individuals with Parkinson's disease, it couldn't be designed much worse. We ask older individuals with impaired mobility and impaired driving ability who live in rural and suburban areas to be driven by overburdened caregivers to urban centers that are large and complex to navigate. About 10 years ago, my colleagues and I said, can we use simple video conferencing, essentially Skype, to provide care to individuals in nursing homes and then more recently directly into their homes? The idea is, can we bring care to patients instead of bringing patients to care? 5 years ago, with generous support from PCORI and with great support from Kathy Gergel, we conducted the first national randomized controlled trial of virtual house calls for a chronic condition. We took 200 people with Parkinson's disease and randomized them to receive the usual care that they're receiving in their community in 22 states around the country, or to receive the care that they're receiving in their usual community, say in Baltimore, and to be supplemented with that usual care with virtual visits from a specialist licensed to practice in their state. We found, one, is this feasible? Can we connect to older individuals with a chronic neurological condition directly in their home? Indeed, over 90% of our video visits were completed as scheduled. If you compare that to show rates for in clinic, it's actually higher. We showed that clinical outcomes were comparable between the two groups. Each virtual visit saved patients and their caregivers 3 hours of time and 100 miles of travel. We had high doctor satisfaction and high patient satisfaction. 97% of patients were satisfied or very satisfied with the care they received, the convenience of the visit, and the comfort of the visit. At the end, we asked patients what should they prefer: the usual care with a doctor that they actually rated highly, that they'd been receiving their Parkinson's disease care from for many years, or their virtual visits from a doctor they had actually never physically met and seen 4 times over a year. On every aspect that we measured, patients preferred their virtual doctor that they had never met, including the quality of their personal connection. So with those results, and again, continued support from Dr. Joe Selby's group at PCORI, we received a dissemination and implementation grant. And currently, we care for 300 New Yorkers throughout the state with Parkinson's disease. If you live in New York State, you speak English, and you have Parkinson's disease, we care for you regardless of who you are, where you live, or your ability to pay. If anyone has a friend or family member who has Parkinson's disease, lives in the state of New York, you can go to our website right now. It's a 30-second enrollment form. Our research assistant, Alistair, here and in the front row, who has a poster, would be happy to set up any of your friends or family members with Parkinson's disease, and they can receive care from one of my colleagues or me. The individuals in this program right now, the average age is 70. The oldest person was 92. He was living with his son in rural upstate New York. He died recently after receiving care in home hospice. I think I saw him last remotely about 1 month before he died. 69% of our individuals live in health professional shortage areas. Only 50% have a college education. 20% are homebound, which means that essentially they leave their house less than once a week, chiefly to see a doctor. Think about that. If you're homebound, the chief reason you're leaving your house is to see a healthy clinician. So what are the barriers to making this available to anyone, anywhere? And the biggest barrier is Medicare. So Medicare was created in 1965. At that time, half of older Americans lack access to health care. And Medicare has been a boon for older Americans, especially those with acute conditions. If you have a heart attack, if you have a stroke, if you have a COPD exacerbation, you can go to a hospital and receive excellent care and largely not have to worry about the financial consequences. But if you have a chronic condition like COPD or Parkinson's disease, the system is not set up to meet your needs. In 2016, Medicare spent $600 billion. Of that $600 billion, they spent less than $30 million. That's actually half of a dollar sign. I was being generous with the slide on telemedicine. So less than 1/100th of 1% of Medicare's budget in 2016 goes to telemedicine. Currently, Medicare incents institution-based care and disincents patient-centered care. If you come and see me at the University of Rochester for a follow-up visit, Medicare pays me about $200. If you come see me in a community-based clinic closer to your home, Medicare pays me $100. If I see you on your terms in your home, Medicare pays me $0. It's your taxpayer dollars. You've been paying into the program for 50 years. It's designed to guarantee access to healthcare for older Americans, and 40% of people with a chronic neurological condition don't even see a neurologist. Fortunately, thanks to Pete Corey and others, and technological advances, we increasingly have the ability to see anyone, anywhere. If you think about the history of medicine, the care you've received has largely been dictated by one of two factors. The first factor is who you are. Are you the right age? Are you the right race? Are you the right sex? Are you the right creed? Are you from the right social strata? And the second one is where do you live? Do you happen to live near Johns Hopkins? Do you happen to live near Boston Children's Hospital? Do you happen to live near the University of Rochester? We increasingly have care models that can reach anyone, anywhere. The only remaining question is whether we have the will. Thank you.